Well, good evening, everyone, and thank you for joining us for this great webinar this evening. My name is Kevin McCauley. I'm with Henry Schein Canada, part of the prosthetic solutions team here, focusing on the newest technologies as well as all the CAD/CAM systems. And I want to thank Nagma Hafazi as well for working on this great session and for coordinating everything for us. I will turn this over shortly to our great friends with Frederick over at Kube Innovations to do a more formal introduction of the speakers this evening. But I'd first like to thank Dr. Barzilay and Behrooz for doing this seminar for us this evening. So if I could, Frederick, I'll turn it over to you, and thank you very much for the webinar.
Well, I want to thank you, Kevin. It's been a while since I've heard your voice, but it's good to know you're doing well there at Henry Schein. It is a pleasure for me and for Ella to be presenting to all of you tonight. We are both prosthodontists. We practice in Toronto, and we are very happy to do this. Generally, when we find something like this, something that we get really excited about, we like to talk about it. So that's really what this is all about. So we are here in Toronto. It's been a long day here in the practice, so we are actually talking to you from the practice. If you see some background stuff like papers and stuff, well, that's how a practice works. If you need to get in touch with us, this is my email. It's my first initial, last name @buildyoursmile.com. And this is Ella's email. Again, initial, last name @buildyoursmile.com. So once again, we're very happy to be here with you tonight. And we hope you enjoy what we have to say, because this kind of thing really excites us. So we hope that it's infectious. If you want to know more about where we come from, again, the website, www.buildyoursmile.com. And I should say that although I would love to be receiving payment for tonight's presentation, neither myself nor Ella are receiving any form of compensation for tonight's presentation, nor do we hold any kind of ownership or anything like that in any of the companies. So, the practice that we practice in is Prosthodontic Associates. It's a large specialty practice at Yonge and Eglinton. We have 10 dentists working here in the practice and about 20 support staff. And we're all specialists within the practice, and it's multi-specialty. So we have prosthodontists, we have endodontists, oral surgeon, periodontists, and we've all found a wonderful way to work together. Now, it's taken a long time to build this practice. This is our group, and a lot of pretty handsome and very attractive people in this group. We don't look like this every day, but obviously on the day of photography, this is what we look like. So our history is we initiated our private practice in 1987. And in 1987, it was really just me. Over time, or at least at that time, we had one dental assistant, we had one reception person, and we had one lab person. And then again, as time went on, we brought in our first prosthodontic associate. And then what we did is we brought in our second prosthodontic associate in 2004. Our first periodontist associate in 2005, and we've continued to grow. We started off with a small space of about 1,200 square feet, and now we're up to about 8,500 square feet, and we are continuing to grow. Well, what are we going to be talking about tonight? Well, we're going to be talking about a device that you may or may not have heard about, and in fact, the first time that we heard about this was last year at Spectrum Day. So the office as a whole goes to Spectrum Day, and in this last one, myself, Ella, and Effie Habshaw, we all were lecturing at Spectrum Day. Some of our staff, in addition to that, were lecturing. And towards the end of the day, as we were going about the exhibits, we passed by this booth that had this really cool looking device. And Ella and I just sort of stopped and looked at it and we said, is that what we think it is? And in fact, yes, it was. It was a way to measure overall bite force and give it a number. And it was something that we had talked about for a long time. And here's Frederick, who's standing at the table, showing people how this thing works. So we walked over and we said, I think we need to have a talk. And that's what started all of this. And really, it was quite remarkable as to what this thing could do and how it made us think differently about occlusion and about restorations. So let's just talk a little bit about digital information. And depending on the kind of practice that you're in, there are a lot of different ways that we use digital information. We use it from a photography perspective. We use it from a radiology perspective. We use it to make records of the bite, of the position of the joint. This is a digital Facebook. And really what we're trying to do is create a digital patient. We're trying to get all the information about a patient into the computer. And with all of this information, we're then able to produce good treatment plans. We're able to follow our treatment plans, and we always have that information with us. Now, there's nothing wrong in doing conventional impressions, whether they be with a polyvinyl material or a polyether material or an alginate. But I think we all understand that these days there are other ways to do this. And this is just a whole bunch of different scanners that are out on the market. And in fact, there's lots more than this these days. It's hard to keep track of all the new ones that are coming out. But this happens to be a technology that's becoming very, very common, and we're really making use of this here in the practice. We're making use of this so that we can record the teeth. We're making use of digital technologies to record the face and the face shape and how the jaws actually come together. And if we can actually get a digital patient, there are a lot of things that we can do that will really help that patient in future treatment planning. This is an interesting program where it's a subtractive program, and you can scan a patient on day one and then scan them again a year later and see what's actually happened to the teeth and see what's actually happened to the soft tissues. Has there been recession? Has there been wear? Not only has there been any, but how much has there been? And this kind of technology is readily available today. It's only been recently that we've been able to get this and use this. So this is something that, as a prosthodontist, I like to have because I get patients who are sent to me for issues of wear. And I need to record what they came in with, and I need to be able to follow them over time to see if the wear is active or not active. And this is a very good piece of technology. Now, along with that technology, we can also measure where there are bite positions that patients have, and much like this. And in addition to this, we can use digital technologies for shade selection. There's a lot of things that we can do. We can do almost everything with some of these digital technologies. And with that being said, I'm going to turn over the microphone here to Ella in just a moment. But I want you all to know that we do have some polling questions. Let me explain what polling questions are. Polling questions is the way that we can give you CE credit for what you're listening to tonight, which means you must be sitting at your computer and you must answer these polling questions so that we know that you didn't just turn on your computer, leave, and then come back an hour later. So that's what a polling question is. So what we're going to do now is we're going to put up the polling questions. Why don't we put up the first polling question? Okay, so have a look at this and go ahead and enter your answers. Okay, they're still coming in. Five more seconds. And we are good. Let's go to the next polling question. Actually, this shows the results. So if you look here, are you comfortable with digital technologies? 63% said yes. Do you use an intraoral scanner? The vast majority don't, but you can see the ones who do use the intraoral scanner. Okay, wonderful. So we've shared the results, and I'm going to ask Ella to come on now and take over for this next part.
Hello, everyone. I'm very excited to be here tonight talking to you about a topic that, again, as Dr. Barzilay mentioned, is very interesting to all of us, especially to us prosthodontists who deal with occlusion, bite force, and complications associated to occlusion and bite force on, I would say, on a regularly or a daily basis, in fact. So before getting into the exciting component of the presentation, which is talking about the device itself, I'm going to take a couple of minutes, not too much, just giving you a little bit of information regarding occlusion and bite force in general, because I believe that knowing this will help us interpret the numbers and the results that we see with different devices that we use and the particular device that we're going to be introducing to tonight. So generally speaking, bite force is based on the literature an indicator of the functional state of the masticatory system. So it is an important indicator of the health of one of the most important systems that we deal with on a daily basis. Generally speaking, it is much stronger in the posterior part of the mouth or the oral cavity than the anterior part. And generally, it is about 3 to 4 times higher in the posterior parts than in the anterior parts. It is a function, or basically an accumulation of the action of your elevator jaw muscles, the number of teeth present. So generally speaking, patients with more teeth will generate a higher bite force. The condition of the dentition, healthy teeth, which are not mobile, which are not periodontally involved, which are less restored, generally do generate higher bite forces, and the pain threshold of the patient. So it might be that the elevator muscles work perfectly. We have an intact set of dentition, perfect set of teeth in great condition, but the patient is very uncomfortable putting teeth together for whatever reason. And we'll get into details about that. So as I mentioned, the bite force is highest in the molar region. And if we want to put numbers to different measurements that we can have, generally speaking, if we do a measurement unilaterally in the molar region, we are looking at about 300 to 600 newtons in terms of the numbers that the patients can generate. In the anterior teeth, if we're only doing a localized measurement, we're looking at about 40% of that unilateral force that is generated by the same patient in the molar region. If we do a measurement of the premolar teeth, it's typically about 70% of that measured number, which is the unilateral force of the molar regions. And if we are looking at the molars bilaterally, then it's typically 40% higher than the unilateral measurement, not double. So that's those are interesting numbers to know. And I think it helps us to interpret some results and numbers that the device that we're going to introduce tonight is going to give us. So a couple of basically general knowledge items regarding bite force is that it is higher in adults than in children. So if we are doing bite force assessment in kids, we do tend to look at lower numbers, and we do have to be anticipating lower numbers. Patients who present with a rectangular craniofacial morphology generally present with higher bite force numbers. And again, patients who do have a skeletal deep bite as well do present with or are able to generate higher forces than patients who have open bite. The maximum voluntary bite force that can be generated typically is higher in males than in females. So it is gender related, and it's also age dependent. So younger individuals, not children, but younger individuals generally can generate higher forces than patients in an advanced age. But as age increases, this correlation sort of decreases or becomes less strong. Now, why is it important for us to know about the bite force or to be able to assign a number to the bite force that a patient can generate? What do I mean by a low bite force? So basically, very simply said, it's when the patient is only able to generate very low numbers or low forces when they put their teeth together or clench their teeth together. Why is this important? Because literature suggests that patients who have a low bite force typically present with difficulty in efficient chewing. They basically report a negative effect that this is having on the quality of their lives. It does determine some of their nutrition decisions. They tend to lean towards softer foods, maybe stay away from nuts, many nutritious foods that typically would require a little bit of a higher bite force to be generated for proper and appropriate mastication. So it affects their choice of foods and as a result, their quality of life. So it is important for us to know if our patient is generating a low bite force. High bite force is also very important. And why is that important? Because as we can all relate to, we can all see tooth-related or restoration-related or implant-related complications when the patients present with high bite forces. Plus, there are times that we also see hypertrophy of the muscles of mastication, but I'm going to be talking about the first three items in a little more detail. So when the patients present with a high bite force, there are some tooth-related complications that can be anticipated. And some of them, not all of them, so this is by no means a comprehensive list, but some of them are listed here. So patients can present with a cracked tooth syndrome, and we all know how very uncomfortable this syndrome can be for the patient. Fractures, vertical root fractures, are one of the most challenging situations in dentistry in the sense that typically a tooth with a vertical root fracture presents with a hopeless prognosis, and we're looking at removal of the tooth and with or without a replacement. So that's never a good day when we're basically communicating to our patients that a tooth is fractured. There's also the phenomena of tooth surface loss or wear of teeth, which can be correlated with high bite forces generated by patients. Mobility can result in traumatic occlusion. Loss of vertical dimension of occlusion as a result of tooth surface loss is another complication which can be anticipated in patients who generate high bite forces throughout a prolonged duration of time or period of time. We're also looking at restoration-related complications. So these patients can present with fracture of the restorations. There might be missing components or missing parts of the restoration, wear of the restoration, and if the patient presents with a heavily restored dentition, meaning a lot of the teeth are restored with different types of restorative materials, and there is significant wear associated with these restorations, again, loss of vertical dimension of occlusion can be anticipated. So these are all challenges that we need to deal with restoratively, prosthetically, when the patients generate high bite forces, again, during a prolonged period of time. With implants, which again, more of us are doing more of on a daily basis, there are also very many mechanical complications that can be anticipated. Regarding implant failures and high bite forces, we generally talk about implant failures in the category of either biological failures or mechanical failures. And the literature is very controversial regarding the association of high bite forces with biological failures. However, it's pretty clear that if there are high bite forces, we do have higher chances of mechanical complications or mechanical failures of dental implants. Now, these can include simple or ready to easily fixable complications, such as fracture of the veneering porcelain, or a screw loosening, or fracture of screws, or it can be a serious complication such as the fracture of the implant fixture or the implant body itself. So these all can be associated with high bite forces generated by patients. The problem with mechanical complications with implants is, unfortunately, the literature is not very clear on what numbers should we be looking at when we're looking at the crown to implant ratio, or when we're looking at what number of or what bite force is a detrimental bite load or bite force for a particular patient. What bone quality or quantity is required to resist particular bite forces in a particular patient. So these are all elements that need research or more research to be conducted on. However, we do know that in patients with high bite forces, again, prolonged period of time, there are mechanical complications that can be anticipated with dental implants, and they're not easy to fix. So generally speaking, when we're recording the bite force, this typically is recorded during maximum clenching, or when the patient is biting, so to speak, as hard as they can bite. It depends on where we're doing the measurement. So location of the measurement is important. The number of teeth that are included is important. And whether we're using any sort of splint or coverage or any sort of protective mechanism on the teeth or the transducers or on the restorations, that also plays a role. So now, with that being said, we're moving on to the next section of the presentation, and we are ready for our next polling question here. And we're excited to see what your answers are going to be to those questions. Yes. So we're still getting some answers to both questions. In fact, we were very interested to know if there was a comprehensive course that would be put together on the art and science of occlusal adjustment, how many people would be interested to attend, just because we do believe that there is probably a little bit of a lack of education during dental school with a good understanding of occlusion and occlusal adjustment. So I do see that most of our participants here tend to be somewhat comfortable adjusting occlusion on different tooth and implant supported restorations. And about 67% of our participants would be interested in a comprehensive course titled The Art and Science of Occlusal Adjustment. So with that being said, I'm gonna ask Dr. Barzilay to come over and talk to you a little bit about bite assessment.
Okay, wonderful. So let's talk about bite assessment. Okay, so bite assessment, how do we actually look at the bite? Well, there's a few different ways of looking at it. We need to identify where it is. We need to quantify, meaning figuring out how much it is. We need to locate, and we need to assess the bite force. And this can be done either in a conventional way. It can be done, and when I say conventional, I mean non-digital. So we all went to dental school. We were all given articulating paper, and we were told, go use it. Honestly, I don't remember being told how to use it, but I was just told to go use it. So we all went and we used it. And I don't know how different that is today, but that's a very non-digital, conventional kind of way of figuring out occlusion. But there are some digital methods, either using a T-scan and also the Innobyte, which we'll spend a lot of time talking about. Now, when we make measurements of the bite, we have to make sure that the subjects or our patients are seated, they're looking forward, and they're in an unsupported natural position. That's the best place to look at their bite. Now, over time, there have been a lot of different ways of looking at bites. This is a dynamometer, which is an old device looking at bite forces. Okay, here we have a bunch of strain gauges that are stuck to a denture that are going to measure the amount of bite force you can get out of a denture. And historically, people have tried to do this, but really until recently, there hasn't been a really good way of doing this. So if we go and look at our conventional methods of looking at bite assessment, we are in fact looking at articulating paper. And articulating paper comes in different shapes and sizes and thicknesses and colors, different ways of holding it. And it's not exactly the most accurate way of looking at the bite. If you have lots of experience with it, it is a great way of locating the bite. And if you're able to read what it's really saying, then you can use this and it can work pretty well. One of the things that people forget to do with articulating paper is they forget to change it. So you can use articulating paper once or twice and then you got to throw it out. I've seen too many people use it 20, 30 times and wonder why it's not marking anymore. So that's just one of the methods of doing things conventionally. We also have shim stock. Shim stock is a very thin foil. Some shim stocks have ink on one side so you can mark spots. And again, these are very thin. These are anywhere between 8 and 14 microns thick. You can't feel them between your finger, but you can actually tell when a tooth is holding occlusion, when it's holding shim stock. We can also use bite registration materials, and we actually do this a lot in the practice. We will take a polyvinyl bite impression material, like a blue mousse or something like that. We'll make a bite registration with it, and then we'll hold it up to the light, and we'll see how much light passes through it. And in doing that, we understand where the contacts actually are, what parts of the tooth are close to contact but not quite there, and what we need to do as far as our next adjustment is concerned. So that's just another way of using conventional materials to make this happen. Now, if we go to a digital format, it is possible to map out the bite, much like the bite registration does, but in a digital way. And that's really what this kind of picture shows. It shows where the bite is actually connecting, and it shows what areas are close to connecting, and so on. Now, if we want to really get more information, not just about where the bite is, but let's start talking about what the bite's actually doing. So this is the T-scan. Now, the T-scan's been around for quite a while. It is popular in some circles, but not a lot of people understand the T-scan. And it's a very interesting device. In fact, it's using a thickness sensor that is very, very thin. It's about 100 microns thick. And when a patient bites on it, you get a mapping of the bite. And you can see what bites first, what bites second, what bites third. And you can see that right across the arch. You don't know exactly what these measurements are. All you know is what comes first, second, and third. It's actually a video. So if a patient bites somewhere first, you know where it is. And that's an important point of information. And sometimes on our very troublesome occlusal patients, we need this so we can understand exactly what it is that they are feeling. But overall, this system does not give you a number. It tells you which tooth bites harder and when. But again, there's no absolute value of the strength of the bite. So you can have a person biting with very low overall forces still show a similar picture to somebody with very heavy forces. What other digital method do we have? Well, we have the Innobyte, and that's really what we're here to talk about. And I will tell you that this is a very simple tool. It's a lot simpler to use than the T-scan, and you know what? It's simpler to use than articulating paper, because you're not really using this to adjust particular spots. You're using this to assess the overall bite force, which then allows you to make some treatment plan determinations. That's how we've looked at this. So this is a bite force assessment technology that does measure overall bite force. It is made by Kube Innovation, really a very inventive company. And in fact, when you look at the bite force, this is what you're going to see, and this is what it looks like. So with that being said, Ella will come on and talk about the uses of it, but I believe we have another polling question. Let's put that up. So this is a single question. Please go ahead and answer. Okay, still some answers coming in. Okay, so if we look at the numbers that are coming in, basically we're looking at 86% don't use digital occlusal assessments. And in some way that relates to the number of people not using scanners. That's interesting. That's very interesting. Well, I hope by the end of this presentation, you'll see that you don't need a scanner in order to make use of this particular device and still call yourself digital. So with that being said, I'm going to turn the floor over to Ella.
Okay, so this part actually gets me very excited because these are things that I can use in my everyday clinical practice, communicate to them, to my patients, to the dentists that I work with, to my colleagues regarding the benefits of being able to associate one number to the bite force of your patient. So in very simplistic terms, what can Innobyte do for you? It can demonstrate the current bite force status to your patient, suggesting a need for treatment. And we'll get to more details regarding all of these items with examples. It increases treatment acceptance rate in less time because the number that the patient sees means something. It's a very simple interpretation. The patient sees a number, you see a number, and basically there are associations that can be made, and there are basically it has a prognostic value. This number has a prognostic value in very many situations where we're faced with a dental dilemma, and I'll talk about some of those examples. And it helps you to design and modify your appliances to moderate your bite force and decrease complications. How does it do that? Let's get into some details. So, demonstration of treatment to patients. Visualize occlusal related number by the patient. So patients generally, unless they're dealing with some sort of occlusal related complication, do not know how much force they generate. Typically speaking, it's very uncommon to have a patient come in and say, I generate high bite forces and therefore these are the consequences or these are the complications I'm facing. They may come in and say, you know what, everything that my dentist does for me, I fracture it in a couple of months. Or a patient with a complete denture might come to you and say, I cannot chew properly. I'm swallowing big chunks of food. So those are typically what the patient's going to communicate to you. When they visualize a number, then everything basically is put into a folder for them, which is easier to interpret. And it's easier for them to internalize what you're telling them regarding the care that they need. It's very easy for us to compare or show the patient a comparison of bite forces which are generated with different treatment options. I'll give you an example here. A patient comes in with complete dentures, maxillary mandibular complete dentures, that you see are completely worn down. The patient does report that they have difficulty masticating. They are swallowing bigger chunks of food. And you see a loss of vertical dimension of occlusion because of the fact that the denture teeth or the prosthetic teeth are worn out. Now, if I duplicate these dentures, and if I add acrylic, it's a very inexpensive thing to do. If my lab gets to add acrylic to the surface of these prosthetic teeth to establish a new vertical dimension and establish a better occlusal scheme and establish a better relationship of a better cuspal relationship between the maxillomandibular prostheses, without the patient having to commit to new dentures or to an expensive care. And if I insert those denture models in the patient's mouth and ask them to bite down, and if I see differences in the numbers, then that is the best way I can tell my patient that, yes, with new dentures, I can give you a better biting force. So it basically generates a very interactive, interesting treatment planning session with your patient. The numbers are ready to see, readily visualize or visible, and the patient can very easily interpret them. So, and we obviously help the patient to interpret them, but this is one of the uses of Innobyte for you. The other use is that basically the same thing, visualizing treatment outcome. I talked so much during the previous slide that basically I covered my second slide, leading to acceptance of treatment. So this is probably the most important use that you can get out of this device, this very simple to use device. And you can design and modify your prostheses and appliances. So this device gives you the opportunity to assess the overall bite force. Tell the patient, okay, you have high occlusal forces or you actually have low occlusal forces. The fact that we, in general terms, prescribe a mouth guard to every patient is probably not necessary. The fact that we, or how do we decide what type of denture teeth to use? How do we decide what kind of occlusal anatomy for full arch implant supported restorations to use? Do we just go for flatter occlusal anatomy, smaller occlusal tables for everyone? Do we really need to do that? Or there are patients that we can actually give them more aesthetic, more prominent occlusal anatomy without anticipating any issues. So those are details that set people apart in practice. So you can modify your treatment to customize it to your patient. Modify occlusal schemes with heavily restored teeth, heavily restored tooth-supported restorations, implant-supported restorations, or removable prostheses to harmonize that bite force. Again, customized to that patient that you're talking about. So now some examples. So I think that one of the most important uses of these devices can be the communication of prognosis of teeth when we have a compromised ferrule. And why do I say that? There are patients that present to your offices and they have a couple of teeth that need full coverage restorations or crowns. And once the decay and all the previous restorations are removed, we know that the number one factor which determines the prognosis of heavily restored teeth is the amount of remaining sound coronal tooth structure. Textbook. So is it always that easy to assess this amount of sound coronal tooth structure? No, it's not. We know the textbook says ideally you need 1.5 millimeters or 2 millimeters of ferrule circumferentially, but there are times that you have it on the buccal, lingual, and mesial, not on the distal, not on the mesial, a little bit compromised on the lingual, but okay on the buccal. How do I make those decisions in a patient who needs a lot of full coverage restorations? They're going to be investing in crowns. They want to know the prognosis. So an occlusal evaluation really does help you, because what does ferrule do for me? It prevents fracture. What causes the fracture? Heavy occlusal loads. So if a patient comes with compromised ferrule, but generates barely enough occlusal forces to chew gum, then I'm comfortable proceeding with full coverage restorations, even if my ferrule is compromised. Even, I'm not suggesting go below 1.5 millimeters, But I'm suggesting if you have buccolingual ferrule, which is more important than mesiodistal, and if you have maybe some ways to obtain a little more like a clinical crown lengthening without compromising anything else, or if you basically see that the patient generates very, very low occlusal forces, then you're more comfortable telling the patient, you know what, Mr. So-and-so, Mrs. So-and-so, I'm comfortable giving you the crowns. I think you're going to keep them for a long time as long as you keep things clean. So it's a very important tool to assess the prognosis of compromised teeth when there are many of them, and sometimes you're puzzled as to what to tell the patient. This is just one of the things that it can do for you. Other thing is, there are times that we really know that a complete denture is not going to work for this patient. You know that in a couple of months, they're going to wear everything out, they're going to fracture things, they're not going to be happy, things are going to be moving around. So it is very safe to tell the patients that literature, strong literature suggests that chewing efficiency and maximum bite force does increase significantly when we have overdentures which are supported by teeth. So if you can keep a couple of teeth, use them as overdenture abutments, or if you can have some dental implants placed and put a bar on top, this does improve the maximum bite force for patients in comparison to complete dentures, and you can be comfortable communicating that to your patient. So that's something that you can tell your patients regarding bite force as well. Another question is, what material do I use? For a posterior crown, what material do I use? For an anterior crown, for this patient, the patient's a Bruxer, what material do I use? So it's very easy to come, and you might know what material you want to use, but there are patients who do their research and they come in and they know all the different materials that can be used, and they want a strong rationale for the material that you are choosing. How do I rationalize that? By giving them a number which they generate on the device. I tell them, okay, you see, you generate very, very high bite forces. And therefore, I do not want to do an all ceramic crown in the posterior part of your mouth unless it is monolithic zirconia. No, I do not want to give you that buccal cutback, which may actually give you more aesthetic results, but it may compromise the longevity of your crown. Do I do full metal for you? Yes, you know what? For you, full metal is a good option because this is the number that you generate. But another patient may come in and, you know what, I feel comfortable doing lithium disilicate for you even on your 1.6 or on your 2.6. So there are different materials, there are different indications and contraindications for these materials. And one of the most important decision-making factors when it comes to materials for full coverage restorations, we all can agree, is the bite force that is generated by the patient. So for us to assume that all posterior crowns need to either be full metal or full contoured zirconia, all the anterior crowns can potentially be lithium disilicate, or that's not the best way to do things. The best way is to have a number associated to the patient and have a rationale for the materials that we're using. Another important thing that it can do for you is it gives you an indication of what number and size of implants you're going to be using, or you can plan for your patients. Now, we are all familiar with the concept of all on 4, but does that actual all on just 4 implants work for everyone? Sometimes the patient needs 6 implants, 7 implants. How do we make those decisions? How are we able to make those decisions? So generally speaking, we need to know that if a patient generates higher bite forces, there are more off-axial loads on the implants, and there can be mechanical complications associated with these implants. That can go as far as loss of osseointegration. And therefore, we want to know if we're dealing with this patient to maybe go for more number of implants, or with larger diameter implants, or with occlusal schemes that protect implants from excessive off-axial loads. Some of the decisions that we can make here is, okay, maybe split those dental implants if this patient is actually generating very high occlusal loads. Or maybe let's have a group function and not a cuspid rise or not a canine guided occlusion for this patient if the patient is generating a lot of forces posterior in the posterior part of the mouth. So there are very many little yet very important decisions that can be made with the help of an occlusal assessment prior to initiating care. There are a lot of times that we look at cases and we're like, okay, how do we deal with this completely edentulous maxilla? We're going to do a full arch implant supported fixed dental prosthesis on how many implants? 4, 5, 6, 7, 8, 9. How many implants? So that's one of the most important decision making factors is what kind of forces does this patient generate? So we're not just going to go based on the availability of bone. We have to customize the treatment based on the patient that we're dealing with. So this is one of the most important uses that Innobyte has, or digital occlusal assessment can have. Now, larger diameter implants are generally indicated for patients who generate higher bite forces. The same load, but gets dissipated over a larger bone structure surface area, so less complications can happen down the road. So it is something that we can basically communicate to our patients, and sometimes it calls for collaboration with a surgeon to do bone augmentation. There are times there are patients that we can look at and we're like, okay, we can do mini implants, we can do narrower implants in these patients, but we do need to identify those patients that we cannot do narrow implants for. And yes, this patient does need bone augmentation before implant placement because there's no way we can get away with narrower implants. So there are times that this translates into more treatment, but more predictable outcomes. And again, these little things are what set clinicians apart from each other. So again, higher loads generated by the patients call for more number of implants, call for kinder occlusal schemes, call for larger implants, fatter implants, and call for perhaps stronger structures which are splinted together on top of those implants. So these are all decisions that can be made with the number that this device can give you. Another use is position of the implants. So there are patients that you do not want to leave that posterior cantilever for them. Yes, do a sinus lift and provide them with posterior implants because the implant's position in the arch can actually affect the magnitude of force to which it is subjected. So posterior parts of the mouth are subject to more forces, as I mentioned, 3 to 4 times more forces than the interior part. And sometimes if a patient has a very kind low bite forces, yes, we can tilt implants, we can avoid some augmentation in the sinus, and the treatment can be a little bit shorter, the patient can pay less money, but there are times that patients actually have to undergo that bone augmentation, have to undergo placement of implants in the posterior part of the mouth, because this patient's mouth is not conducive to just limiting the implants to the anterior portion of the mouth. So basically, these are all very important decision-making factors when it comes to extensive implant-based care. And this is just an interesting thing that I saw in one of the papers that I was going through, that patients actually do generate higher biting forces on the ipsilateral dominant hand side of the jaws. Now, maybe not very scientific, I'm not sure, but I thought it was very interesting to just have it out there. Now, the device that Dr. Barzilay is going to be talking to you in detail about in a couple of minutes has some advantages. So it is very, very easy to use, very user-friendly, and I'm sure you'll all agree with us by the end of the presentation. You get a number in a very, very short amount of time, less than 30 seconds to use this device and see the number and show it to your patient. It's very easy to use. You really don't need a specific training for this device. If you do, you can contact your rep and they will give you training, but you probably won't need any training. It does provide you with a return on your investment, and it does optimize patient-related outcomes. And how does it do that? With all the examples that I mentioned up to now. So it helps you decide what treatment is best suited for this patient and help them also internalize that decision that you've made regarding their treatment. So it is an interactive decision making, and it is definitely a stronger decision making that we can have here. So very accurate and practical as well, which helps with, it's another advantage of this device. With that being said, I think everyone's ready to know how exactly this bite force measurement tool is used. But before doing that, we do have another polling question that we would appreciate if we could have here. So this question says, do you think there is value in knowing maximum total byte force generated by a patient and to determine materials to be used in prosthodontics? And I'm very, very happy to see that no one said no. So I'm very happy to see that more than 90% of us agree that there is value in knowing the maximum total byte force, and the rest also say maybe, which makes me very, very happy. And with that being said, I think I'm gonna let oh, there's a no. Okay. This person didn't like me. Anyways, okay, so I'm gonna let Dr. Barzilay take over at this point.
I can't believe someone said no. Like, really? Really, after that argument for materials and stuff, somebody actually said no? Why would someone say no? Well, because there are people who think that maybe using the strongest material in every situation is a reasonable approach. So let me just address that, because I know that I've talked with Ella about this many times. It's okay to use the strongest material everywhere. But then when you have to remove that strongest material, let's say zirconia, for those of you who've had to remove zirconia crowns, you know how much fun that is. It really is not a lot of fun. So not only do we choose the material based on byte forces, let's think about what happens when we have to service these restorations and remove them. That's another issue altogether. But it's okay, you're allowed to say no. It makes everything look a whole lot more accurate. Thank you, Ella. Okay, so let's look at this device. The kit is really simple, okay? And you don't need a scanner and you don't need a computer even to do this. All you need is this little beautiful white box that comes from the manufacturer. And there are 3 items in the kit. There's the reader or the device, there's the mouthpiece, and there's the cable. And that's pretty much what you get in this device. Now, you turn on the device by pushing a central button, and then it tells you to hook up the other pieces. What does that mean? That means that you connect the cable. Okay, so you attach the cord, and you attach to the other end of the cable, you attach the mouthpiece. The mouthpiece is, if you feel it, it's going to feel like a heavy piece of silicone, and there are a bunch of sensors inside. That's what I'm assuming is in there. Now, because you can't really run this thing through your sterilizer, you're going to put on a protective cover on this mouthpiece so that you can place it in someone's mouth. You then position this in your patient's mouth, and on the inside of this mouthpiece, there is a little groove, and that is placed right between the central incisors. And what you then do is you can measure the bite force by telling the patient to squeeze onto the device. So again, you line it up with the incisors. The patient will then bite as hard as possible for 1 or 2 seconds, and then you can do it a few times and see how the numbers differ. I will tell you that if you do this too many times, the patient does start to get tired and you start to see a change in numbers. So normally we do it once, twice, maybe 3 times. And what is nice is you can see the results immediately on the device. And in fact, we have the patient hold the device so they can see the numbers themselves. And when you're done with it, to turn it off, you just simply put it aside and it goes to sleep. Now, once you have your numbers, you can interpret the results and you can communicate it to the patient. And you can show them a reference chart. Now, this is something that was made up by the company. It just breaks up the numbers into very small to very large. That's all it really does. And it looks something like this. So if someone is above 1,000, they're in a range, and this is 1,000 newtons. This is pretty hard. They're in the range of what's called superior. They're in the range that they're going to break everything that you do. They're in the range that when they grind their teeth, there's nothing left. It's that kind of group. And then you can go down to that lower numbers, those lower numbers, which is where you tell a patient to bite down on articulating paper and you can't see any marks. And you say bite harder and you still can't see any marks. And it's because they just bite in with a very low bite force. Okay. So after you've used it, you disinfect it, and the device will work for up to 1,000 measurements. And at the 900 measurement mark, you're going to be told that you're going to have to make some replacement. So again, what's the importance of the bite force? Ella really talked about these things very well. But basically, if you go from an old denture to a new denture with optimized vertical dimension, with new teeth, with a proper occlusal scheme, you're going to improve bite force. When you go from a complete denture to an implant over denture, you're going to improve stability, support, retention, and bite force. When you go from a complete denture to a full arch fixed implant supported bridge, again, significantly improved stability, support, retention, and bite force. So we understand the role of dental implants because they do help us improve bite force, they improve chewing efficiency, they enhance patient satisfaction. So what are some of these clinical cases? This is a 58-year-old female patient, came in with old dentures, and with those dentures in her mouth, she could generate 122 newtons. Just by making new dentures, changing vertical dimension, she was able to then generate a 272% increase in her bite force. This is a 65-year-old female patient, edentulous for 35 years, and her previous dentures were 12 years old. So the dentures that she came in with generated 223 newtons. By putting in some implants and just putting on some healing abutments. Okay, so now the denture has some support from the implants. You've gone from 223 newtons to 506 newtons. And if you add a bar, which gives you even more support, you can take it up to 785 newtons. And again, this shows much the same thing. Old dentures that have a loss of vertical dimension of 4 millimeters. And once you put in new dentures with implants and a bar, you go from 307 newtons to over 1,000 newtons. Another patient, 231 newtons generated with old dentures with a reduced vertical dimension. By fixing the vertical dimension, adding some implants, adding a bar, again, you're going now from 231 newtons to 613 newtons. So, with that being said, I hope we've given you something to think about. This device is a digital device. It is something that does wow the patients. It's a little bit like when we do our diagnostic records in our practice. If you want to impress a patient, either take out the scanner, they're wowed by it, or if you don't have a scanner, take out the Facebook. Go find it in your garage and take it out and use it on the patient. They think that this is the most wonderful device in the world. This has a marketing potential to let patients know that you are in this different segment of dentists who believe in these digital technologies. Again, you don't need a computer for this. You don't need a scanner for this. This is a way to measure bite force. And then you can relate that to what you are doing. It's just an incredible device. It's incredibly easy to use. And we have trained our staff and we have trained ourselves on how to use this. So again, this is something that I think you should give some consideration to. And as I wrap up, I would ask you if you have any questions, you can go into the Q&A section and we'll do our best to answer questions once we're done. So this is actually a slide here of our foundation. And you may or may not know this, but our office is heavily involved in the Build Your Smile Dental Foundation. And this is a group that helps patients, whether they be in international locations or whether they be at home, that need new smiles. At home, we work with some of the women's shelters. We work with some Holocaust patients, and we're always working with patients who need support. Overseas, we work in different locations where we bring dentures, we bring extractions, we bring periodontal procedures, we bring implants to these other environments. And this is a team that we had in Uganda when we were still allowed to travel to Uganda. And I show this because this was another group that we had in Uganda. But if you look up on the screen there, you can see that Henry Schein was one of the sponsors for this particular trip. And we always appreciate the support that our sponsors give us. If you want more information about the foundation, contact us at buildyoursmile.org or contact us directly by our emails, and we'd be happy to talk about whatever you want to talk about. So with that being said, we thank you. Ella and I have been very happy to put this together. Again, when we're excited about something, we like to talk about it. And that's really how this thing goes. So Frederick, do we have any questions in the Q&A that you'd like us to answer?
Yes, so first of all, thank you very much for the great presentation, both of you. The first question that we have is, it's rather technical question, so I'm going to do my best to read it for you. It goes as, have you seen a common thread for fixture breakage on one type of connection more than another with forces?
Do you want me to take that?
Sure.
Okay. Fixture breakages, if you want to relate them to the style of the implant, and I hear Ella giggling behind me because she knows we've had this discussion many times. I'm particular to having a fixture design that has a platform, meaning an external hex, where there is a lot of support for whatever occlusal forces we have. I have some concerns about internal connections of implants because there's a large hollow area if we're going to do a direct to fixture connection with a bridge. So if you are to use internal connection implants, whatever it happens to be, you need to be using some form of abutment that fills in the inside of the implant to make it more solid. And in fact, if you're already putting on an abutment, you're turning it into an external device. So you might as well put in the external hex to begin with. Now, that's what I always say. Now, I'm an old guy. I love external hexes, been doing them for over 30 years. We see fractures with all implants. We're starting to see more fractures with internal connections, especially the narrow ones. So Ella talked about using this device to figure out bite forces, and based on bite forces, start designing your implant cases with appropriately sized implants. These days, again, if you have an appropriately sized or a large internal connection, you'll do fine. Okay, but if you ever stop me at a meeting and ask me what I think, it's always going to be external hex. Ella would give you a different argument, right?
You know what? I think I'm gonna. I don't think that there is strong indication in the literature regarding a preference for any type of connection particular to fractures. However, based on what people who've done this more than most of us, including myself, tell me is that those weaker coronal portions of internal connection implants, especially when the internal connection or the anti-rotational component is long and the implant is of a smaller size. So those two together translate into a very thin titanium wall in the coronal portion of the implant, and therefore it can cause some mechanical complications, such as what we might call flowering with some particular types of implants, or fracture of the implant. However, the literature doesn't really suggest that there is one preferred type of connection in terms of just fracture resistance. So I guess that I hope that that answers the question.
Great, thank you very much. We have a few more questions actually. The second question is, have you used pectin frames in comparison to zirconia on a hybrid? Was there a difference in forces?
Sure.
So the easy answer to this is no, we haven't used them, so I can't answer the question. Next question.
So the next question is, it's more of a comment, but it says that I'm more concerned with bone overload than material failures.
You want to take this?
Sure. So that's a very, very good concern to have. But depending on what concern you have regarding bone overload, the literature, again, I go back and forth with the literature because my thesis project was on implant failures and etiology for implant failures, basically. And bone overload with dental implants is not necessarily a biological issue. There are strong researches out there that suggest that you can have very, very high occlusal forces on the bone as long as they're dissipated through a larger surface area of the bone. And even when we have a single implant, biological failures with bone, with overload of implants, very controversial. Now, there is literature that suggests that there is no association between high occlusal forces and biological failures of implants, which means bone overload and bone loss. There is literature that suggests that there might be microfractures that occur at the level of the osseointegration, which activate osteoclastic activity. Now, it's not that clear, though. The more important concern seems to be mechanical failures. So component fractures, I would be more concerned about them than bone overload in many cases, because sometimes actually very, very challenging to deal with them. Challenging to remove a fractured implant, or challenging to remove a fractured component from the implant. So yes, bone overload can be an issue, but it's not that clear-cut in the literature that bone overload can lead to bone loss or any biological disease in the bone.
Very good. Next question is, how can I simulate my T-scan with the Innobyte?
Did you want to take that?
Let me try that.
Sure.
So if you're using a T-scan, first of all, I want to congratulate you because I think it's a wonderful device. It really helps in a lot of different situations, especially in implant dentistry, when we're dealing with implants that have no movement, and we're also dealing with teeth that have movement. So it's a very interesting device to help pinpoint where some of these forces are coming from. I don't pull out the T-scan for every single patient. I don't do that. I don't think I need to. But I will tell you that it is very easy to pull out the Innobyte and get an overall number, especially at the diagnostic stage, to help us create the overall treatment plan and explain things to the patient. What I use the T-scan for mostly is once we have the restoration in place and I'm fine-tuning it, that's when I pull out the T-scan to make sure that I'm carrying load as much as possible on all of the teeth. And that's sort of how I've connected the pieces.
Great. So we got no more questions, actually. The only other questions are concerning the price of the device. So for that questions and information, I would like you to contact your sales representative from Henry Schein, and they will happily explain you all the prices and descriptions and extra information. So I would like to thank again Dr. Barzilay and Dr. Behrooz for the great presentation on the importance of Byte Force tonight.
Thank you, everyone. Have a good night.